Hello. Today we are going to talk about chapters 1 and chapter 2. So the A and B codes and then the C and D codes for coding. The A and B codes are relatively easy. There's only really two things that I want to point out when you're coding them. One, to give you kind of the definition of what we consider AIDS and what we considered HIV infection. And the second one is to talk about sepsis and the different steps of septicemia, sepsis, severe shock, sepsis. Severe sepsis. So we are going to talk about that first. So the first thing that I'm going to relate is about the HIV virus and what is considered AIDS. So someone can have HIV and it could basically be living in their system for a while without actually developing into AIDS. AIDS is when their immunization system is compromised. So the things that they will be experienced will be related to the AIDS. When they have this, your first code that you're going to put on the principal diagnosis is going to be that they have AIDS, okay? That is the most important thing to relate. So it will be B20, okay? That is full-blown AIDS. I'm going to call it FBA, okay? Full-blown AIDS. They can also have just the HIV virus. So if they have just the HIV virus, but it's not affected their immune system yet, then you want to code it, but it's not the most important code. You will use Z21 for that, and it's never going to be the primary code. If you use Z21, it's not ever going to be the primary code. If they're there because of conditions that are related to their AIDS, okay, so they have a lesion or something like that, then the B20 is going to be the code that comes first it's your primary diagnosis. However, let's say someone fell down and broke their leg, okay, so they went to the hospital because they broke their leg. However, this patient also has the HIV virus. So when you code that, your principal diagnosis is going to be for the broken leg. But an additional code would be the Z21. Because it is important that they know that this patient has the HIV virus. But it is not why they're there today. Today, they are going into the hospital because they have a broken leg. So that would be what you are treating primarily. You would put the Z21 code on there because, you know, the additional codes that we put on there are reasons why we do things or additional information. So the Z21 code would explain why maybe you had to use more supplies because your nurses and doctors would have to be extra careful, or why this patient had to be in a separate area of the hospital to prevent, you know, accidental infection of someone else. So maybe this person has a longer stay because it's going to take him longer to get over his broken leg, or longer for you to treat the broken leg because this person has the HIV virus. So that is why you would code it. So the B20 code, if they have AIDS, if they have the immunization breakdown, then the B20 code will always be listed first. However, if they just have the HIV infection, which I call it activation. I don't know if that's the right term, but it hasn't activated yet. So it's still just a virus in their system, but it's not affecting their immune system yet. Then when they come in, whatever the reason that they're there for, if it's not associated with the HIV virus, then that is going to be the principal diagnosis, and the Z21 code will be listed as basically additional information, why we had to treat this patient a little bit different, why we had to spend more time with this patient. So that's what we are going to focus on for the HIV virus. Okay, the second thing that we're going to focus on is the septicemia, the sepsis, severe sepsis, and what is called septic shock. Okay, so I'm going to give you definitions of those, and maybe that will help you when you code. You'll still need to read the guidelines and firm up on the guidelines, which are in the book, and of course they're in our code book. So let me write down these different definitions. First of all, they kind of build with each other. Okay, so the first thing that would be listed would be septicemia. And that basically means that there's toxic in the bloodstream. All right, that is what septicemia means. It's toxic in the bloodstream. That's not coming very good. I'm gonna see. I'll just use black, I think would be my best bet. All right, so from that, the next step in the sepsis process would be what is considered basic sepsis. And sepsis is septicemia plus systematic inflammatory response system. All right, so sepsis is the next step. So septicemia, toxins in the bloodstream. Then you go to sepsis, which is septicemia plus the systematic inflammatory response system. The next step is severe sepsis. Okay, and severe sepsis is sepsis plus organ dysfunction. So sepsis plus organ dysfunction. All right, so they're kind of stepping up. This one is septicemia. Sepsis is septicemia plus the systematic inflammatory response system. Severe sepsis is sepsis plus organ dysfunction. And then finally, we have septic shock. And septic shock is severe sepsis plus organ shutdown. All right, so the difference between organ dysfunction is when your organs are stressed and they're doing things incorrectly and you can tell that there is an issue. Organ shutdown is when they die. So your lungs no longer work, your kidneys no longer work. It's shut down. This is where they're struggling, but this is the difference. Organ dysfunction is struggling. Organ shutdown is exactly what it says. It's shut down. They're off. Okay, so these are the 4 different things that you're going to be looking at. I just wanted to explain what was considered sepsis, severe sepsis, and septic shock. So they build on each other. Septicemia, sepsis is septicemia plus SIRS. Severe sepsis is sepsis plus organ dysfunction. And then septic shock is severe sepsis plus organ shutdown. All right, so that is basically the things that you need to know about the A and B. The other thing that comes out in the guidelines is that when you have the name of one of the things that the causal bacteria, then you need to list that also. Those are going to be in your B95, 96 area. So if you know what is causing the bacteria, then that is going to be listed when you're talking about your A and B. But those are also notes in the tabular. Just like this, when you're using this, if you go to the tabular, it's going to straighten out like what other codes, because it'll say list first or code additional information. So make sure that tabular is so important. Main term, alphabetic index, the tabular wraps everything up and tells you, if you have questions about what needs to be coded as well. All right, so that's that. Now I'm going to move on to the Neoplasm chapter 2 in your code book. And this one has a ton of guidelines. So it's one of the harder chapters, I think. But if you get down the guidelines, then you're going to be okay with that. So the first thing that we need to talk about is what cancer actually is. And this is a picture in one of my books that I think kind of sums it up exactly. Okay, so when you have cells, your cells divide. And if you have normal cells, then they divide along a much, they divide, then they divide again, again, but it's all straight. It's all very organized. Once you have cancer comes in and then things start to break apart, and then they break, and every time they divide, they're still dividing like they were, but they just become a big old mess. I mean, they don't line up properly, they don't function properly. So that's kind of the basic, that's cancer in most simplest terms, is that when the cells divide, they do not divide like they're supposed to. They don't look like they're supposed to. They don't act like they're supposed to. So that's kind of the basics. So the next thing is there are basically 2 different types of neoplasm. So you have malignant and you have benign. Some basic differences. Benign actually usually grows very slowly. It's usually encapsulated and it doesn't metastasize. Metastasize is the word that is used for move. It doesn't spread. Okay, so if you see metastasize, then pay attention to it, because if you have something somewhere that metastasized to, then the first is where it came from. So that's your primary. If you have metastasized from, then where it was from is the primary, because it's where it came from. And I'll go into that a little bit later. So you have benign. Now, malignant neoplasms they grow relatively rapidly, and they are the ones that are going to spread. So benign normally just stays in its little area, but the malignancies are going to spread if they can. So that's one of the things it's bad about malignant neoplasm, is that they're not just going to stay in one area if they have the possibility to move. So there are several complications or things that they can also cause once they have that. There's anorexia, you can have difficulty breathing, there could be fever, malaise, where you just don't feel like doing anything, weight loss. All of these things are neoplasm related if that has been a diagnosis. So there's basically, not all the time, but a lot of the time, when you have a cancer, a malignant cancer, it's going to end in O-M-A, oma. So lipoma, carcinoma, those are going to be kind of some of the ways that you can recognize if it's malignant. It's not going to be the only way, but it is one way. Carcinoma is cancer of the epithelial cells and of connective tissues. Then you have lymphoma, which is cancer of the lymph nodes and the immune system. You have melanoma, which is cancer of melanoma-producing cells. Melanoma is kind of skin cancer, because that's where your melanoma is produced. It's what creates color and things in your body or on your body. And then sarcoma is connective tissues such as blood vessels, bones, cartilage, muscles. These are where that is going to occur. And I'm using my notes here because there's a lot of guidelines, like I said. So I'm going to talk a little bit about the place in the code book where you are going to find the neoplasms. So it has its own special table when you're looking at it. And you have your alphabetic index is here at the front. And if you notice, there's a black area. So there's a black area right here, which is kind of the front. Then the first black area is going to be what's called the neoplasm table. And it is going to be where you get most of your codes. If you have a code like carcinoma, then you can look up carcinoma, and the carcinoma will most likely refer you back to the neoplasm. Treat this neoplasm just like you treat step 2 in the MAT process. So MAT, main term, alphabetic index, and then your tabular. So even though you see codes in here, always double check with your tabular to get the final digits, things like that. So if you notice in your code book, it's divided into 6 different columns. So the first one is primary, malignant primary. The second is malignant secondary. You have carcinoma in situ. You have benign. You have uncertain behavior, and you have unspecified behavior. Okay, so I'm going to go into a little bit of the definitions of what each one of these columns mean so that you'll be able to code with a little bit more information. So the first thing is, I'm going to start in column 3, which is the carcinoma in situ. And basically, that is a malignancy that does not spread, that cannot spread. So for an example of that would be in the breast, because it's not really connected to anywhere else, so it can't metastasize anywhere else. It's basically stuck in that one area, the cervix, places like that. So that is what the carcinoma in situ, or CA in situ, and that has to be documented on the records, specifically those words. So you would never use that column unless it is documented right there. Benign, I went over that. So that's basically if it is not malignant, then you have, so the 4 other things that I'm going to talk about are the uncertain behavior and the unspecified behavior. So when you are looking at, where are my notes running off to? Okay, so when you're looking at the definition, in situ basically means malicious but not moving, or malignant but not moving. I say malicious because mal means bad, basically. So anything that has that as a prefix is bad. Malicious comes to mind. So the malignant in situ means it's not moving. Then you have uncertain. Uncertain means that it's benign and malignant. It has characteristics of both, but it hasn't been diagnosed yet. We can't tell yet. We can't tell if it's just benign. We can't tell if it's malignant. So it's uncertain. We're uncertain as to what it is. Unspecified is basically when the doctor didn't note if it was benign or malignant. And your best course of action in that is to query the doctor, ask the doctor which one it is. Because they have codes for that, but you want to be as specific as you can when you're coding. So if you have the opportunity to query the doctor, that is what you're going to want to do. So now we've talked about benign, we've talked about carcinoma in situ, we've talked about the uncertain, and we've talked about the unspecified. Okay, so now we're going to talk about the malignant primary and the malignant secondary. Now, this is going to be kind of harder to get because it can be a little bit confusing, but the one thing I want you to note is that if it's a malignant primary, that is where it started. It doesn't matter if that's what you're treating. The primary means this was the original site. The secondary is where it metastasized to, where it spread to. So when you're coding, you're going to code which came first. So for example, if you had bone that was metastatic from the breast, then that means the breast is where it started. So when you're coding it, you are going to use the malignant primary column. You are not going to use it secondary because the breast is where it started. And when you're using that column is where did it start. Okay? Secondary is where it spread to, where it metastasized to. So I don't want you to get confused with what I'm going to say right now, but in the columns where you get the codes, it's where it started and where it spread to. So primary is always in the column of where it started. Where it started. And I keep saying that because it's about to get a little confusing here in just a second. So now when you're coding, you might not always be treating that primary site. Sometimes that person may have come in today for treatment of the secondary site and not treatment of the primary site. So the first listed code, the primary code, is going to be the secondary malignancy. So, for example, when you're coding the bone metastatic from breast, then I'm going to write this down real quick. So you have bone. Okay, so the bone metastatic from breast. So this from is very important because it means that this came from this. So this is your primary. This was the first spot. This is your secondary. This is your second spot. Okay, if it had been bone metastatic to breast, then the bone would be spreading to the breast. So the to and the from are very important that you read those and what they mean. So if it comes from or if it's going to, that's going to tell you what's your primary and what's your secondary. So in this case, you have bone metastatic from the breast. So when we are coding it, the breast is going to be our primary code. So we are going to go and look in our table and look at the breast. Okay, so when you're coding in the neoplastic table, you will code from anatomic site. So it's going to be listed as, it could be skin, it could be breast, it could be where it's located on the body. So in this instance, we are going to look at the breast. And I have it in here. So I've opened my neoplasm table and I am looking for the code for breast. So I found the code for breast, but I didn't I didn't have a whole case study for this. So I'm just basically going to give you the basic code without going into the tabular to find the rest of them. So in this case, I'm just going to use the basic breast, which is C50.9 on the primary malignant column. So C50.9, and then it's going to have an additional characters. But for our purposes right here, it's going to be C50.9. Now, primary, it went to, so the breast metastatic to the bone. So this is going to be our secondary code. So when we look up this code, we're going to look for bone, but we're going to be in the secondary column. We're not going to be in the primary column like we used for this one. We're going to be in the secondary for this one. So I'm going to come over here and look up bone in my table. Okay, so I'm going to go along the side here and look for bone, like the breast was right in this area. And then I'm going to go, it's alphabetized, so I'm going to go a little bit further down. And I'm going to look at the bone. Actually, I'm going to go backwards. Apparently, I can't tell my baby C's today. So I'm going to go for the bone and go up to the basic one. Now, when you're looking at this, it's going to be just like the tabular. So you have when you're looking for it, you have to pay very close attention to the indentations. So if you have bone and then you have indents, all of those are in the bone. And then what comes below it, in this instance, you have what comes after bone is going to be the book leaf or the mouth. So it has a whole bunch of different indentations, but you look at things on the indentation that they are aligned with. Sometimes it might be easier to use a ruler to see what's lining up, or the edge of a notebook paper or the edge of a book, something straight, so you can see whether or not it's indented, because everything indented is related to that top discussion, in this case, anatomic site. So in this one, in bone, it is going to be I'm going to the second column. It's very tempting to go to the first column, but it's a secondary area. It's a secondary site. So I am going to go to the bone, and it is C79.51. So this is the code, and I'm just going to use this code in here, but we would always go to the tabular to make sure there are not any additional information, additional notes, things like that. So when you're coding, no matter where you're coding it, whether it's a primary code, it's the primary code, or the secondary code, these are the codes that you would use based on where the neoplasm started. So, for example, let's say that today he is coming in to get treatment for the bone. What's wrong with his bones. So when you do that, when you're coding it, why is he there today? So you come back to that question. Why is this patient here today? He's here today for the bone. So even though it was listed in the secondary column, it's going to be your primary code, because that's why they were here today. It's going to be your first code, because that's why he's here today. If he came to get treatment for the breast area, then that would be your primary code. So when we're looking at the columns, we are only looking at the codes. We're not looking at where we code it. We're just looking at getting the correct code when we're looking at the table, when we're looking through the columns. So hopefully that explains it a little. Why are they there today? We still ask that question. Why is this patient here today? What is being treated today? If it's the bone, that comes first. If it's the breast, that comes first. Let's say he's getting treated for both of it. In that case, it doesn't matter which one is listed fourth if he was getting treated for both of them. So, was having surgery on both of them, then that would be fine. Okay, so I've talked about treatment just then. When the patient comes in and it's for chemotherapy or immunization therapy or radiation therapy, that's going to be why they're there today. So there are codes for chemo. There's codes for radiation therapy. So these would no longer be your primary codes, your first listed codes. They would be there because it's related. It's additional information. Why is this person getting chemistry or getting chemotherapy? Because they have neoplasm in the breast and bone. But that's not why they're there today. They're there today for the chemotherapy treatment. So the chemotherapy treatment would be what your main term. It would be where you would search in the alphabetical index. Also, there are some complications that arise when a person has has neoplasm, has a type of neoplasm, and those are going to be things like anemia, dehydration, pain. So when you are coding those, you're going to come back to the age-old question. Why is this person here today? So if you have a person who is there for treatment of anemia related to the cancer, then the cancer is going to come first. If the cancer caused the anemia, then you're going to list the cancer first, or the neoplasm first, the neoplastic code first, and then the anemic code second. Now, if the person is there for management of the anemia based on a side effect of chemotherapy or immunotherapy, then it's going to be listed first, or radiotherapy. The management for the anemia, like maybe this person had to have a blood infusion because anemia affects the blood. So this person had to have an infusion of blood in order to get her blood count back up, her red blood cells. Then that would be why that person was there today. You would still list the codes of the neoplasm because it is additional information. It's why that person needed treatment for the anemia, but it's why are they there today. So that's how you deal with anemia. All right. Dehydration, because sometimes it causes the body to vomit and get rid of excess weight, water, diarrhea. So that could cause dehydration. And if it is, then you would list the dehydration first because that's why the person is there. So she had to receive like intravenous therapy. A patient might have to receive intravenous therapy, saline, that kind of things, in order to get a liquid into the patient's body. Now, there could also be a surgical procedure performed, and if that surgical, like for example, I'm going to read a little area. It says, Amanda Pan had surgery on a malignant tumor of the small intestine. 1 month after the surgery, Amanda developed an infection that required treatment with antibiotics as an inpatient. The infection is going to be your first listed primary code because the infection is what you're treating today. It's what you're handling today. It's going to be the primary diagnosis. Pain. Okay, so there's some guidelines on how you manage pain. But pain is, a person's going to start having loss of appetite. They're going to have basic difficulty sleeping. Anxiety, all these different things. And sometimes they actually have physical pain. So you might have, they might be given like a narcotic to help treat it. And that is going to be the treatment for the pain. So morphine, I hear a lot of talk about morphine. My stepdad actually died of carcinoma of the lungs, and by the time they caught it, it had spread to his whole body. So there was no way that they could operate because they would be taking out most of him. And when it got toward the end, he was in so much pain that he just had a steady morphine drip because he was out of it, but he couldn't handle that pain. Because, the cells are multiplying, but they're multiplying wrong. They're not doing what they're supposed to be doing. They're not taking your body the way it's supposed to be doing. So your body is eating itself, basically. It's turning itself wrong. So that is one of the things that can happen to a patient. So if the patient comes in for a treatment of pain management, then you would list the pain. Why is that person here today? So that's kind of the best way that I can talk to you about that. I know those are a lot of guidelines, but like I said, neoplasm, pregnancy, those are probably going to be the harder chapters. So if you have any questions, just contact me. You have all of my information on the syllabus. And if you speak to me in person, then I will see you later.